Welcome to our colorectal webinar series. We are in module 5 already, and we will have today module about principles of Icg and fluorescence imaging. It's an honor and pleasure. Colin Sitges, Andreas Chamier, and me are running this webinar series together with Medtronic, and thanks for the big supply we get. There are always around 300 to 400 participants joining all over the world. And it's great to have you here with us. We always have also guests with us. And today it will be Ahmed Shukri Hafez, which is coming from Egypt, and he's the head of the oncological surgery department there. And he will also add his experience. As you see, we have 11 modules overall. We started in June this year with module 1, and we had basic of laparoscopic colorectal surgery. We went through the laparoscopic left colon and sigmoid surgery, also the right colon. And then 2 weeks ago, we focused on special situations in laparoscopic colonic surgery. Today, the principles for Icg and fluorescence imaging will be covered. And then there will come mainly in 2 to 3 weeks distance, always on Thursday in the afternoon, module 6, 7, 8 until 11. For more complex situations. Today we will cover this. Colin will talk about principles of Icg. Andreas will talk about Icg in laparoscopic colorectal surgery, and Ahmed Shukri will have an interesting case for us. And I will give over now and hand for Colin to show the principles and indications of fluorescence imaging.
I will show you a presentation of the use of Icg in general practice. And when I say general practice, I mean my personal general practice, because that differs a little bit from country to country. In my hospital, we both do colorectal and HPV surgery in the same department. So personally, I do both procedures, but I know it's different in other countries. So what will I discuss? A little bit about the background of Icg, the indications, and briefly something about the evidence, because I expect Andreas will do most of the evidence for colorectal surgery. So Icg is available worldwide. It's CE and FDA approved, and there are no absolute contraindications to using this dye. There is a relative contraindication if patients have an iodine allergy. Then we prefer not to use it, but we've never actually seen problems with that. But it's stated that it could be a problem. So Icg is initially developed during the Second World War as a dye for photography. And it was approved by the FDA in 1975 for medical use. And it was initially only used for ophthalmography to look inside the eye and do a fluorescent angiography. And of course, it was introduced many years later during laparoscopy. So that's only something from the last couple of years. So how does Icg work? Well, Icg is given mostly intravenously, and we give it intravenously, it tightly binds to plasma proteins, and it becomes confined to the vascular system. But it is cleared by the liver and excreted in the bile, and half-life in blood is about 4 minutes. So this is really important when you use Icg in clinical practice, because you have to realize where the Icg is in which compartment Icg is. If you want to see it intravascular, you have to look immediately and give it at the same time. But if you want to see it in the bile, you have to give it a half an hour or an hour before the procedure. So you have to realize that. So the maximum recommended doses is about 2 milligrams a kilogram, but you will never reach the dose, because a normal typical dose for a patient studying image is about 2 to 3 milligrams for the whole patient. So don't worry about the maximum dosage. So how does Icg work? Well, if you look in the dictionary at fluorescence, you see that it's spontaneous emission of light by a substance that has already absorbed light. And this is quite important because it means that you need a special Icg camera and you need a special light source. Because Icg is activated by near infrared light, and it emits a fluorescent light with a certain wavelength. So you need a special camera and a need special light source. So there are different, the industry, there are different companies producing the Icg, systems. Medtronic has its own system. So if you want to know more about that system, please go to your local sales contact and ask for product information. So there are different reasons why you want to use ICG. You can use it to get your anatomy visualized better, mainly in the gallbladder, but also in the ureter, but you need a special substance which is excreted in the urine, and this is not available yet, but they're working on it. Perfusion of the colon, we'll discuss that. And personally, I also use it for laparoscopic liver resection. I will show you a video of that later on to get the margins clear. I was asked not to talk about off-label use of ICG. Personally, I think for lymph nodes and lymphatic mapping, there's not sufficient evidence to use ICG on a regular basis, so I will keep from that. So this is to start off with to show you how ICG works during a cholecystectomy. In this patient, the patient received ICG half an hour to an hour before the operation, and you can clearly see the common bile duct and the cystic duct. And just to show the principle, if you're not sure if the structure in the middle is an artery or something else, you can just give ICG, and you're sure if it color screen immediately that you're sure that it's an artery. And now you have your anatomy completely clear. And I know there are people sitting at home questioning, well, if you need ICG for this kind of gallbladder, you might need to stop doing surgery overall. And I agree, maybe you don't need it for this kind of gallbladder. But in this kind of gallbladder disease, you kind of need it, or it helps you to get the anatomy clear much better. This was a patient who had a perforated gallbladder, which was treated conservatively, and the anatomy was not quite clear at the beginning. I was doing the dissection and looking at the lower border of the gallbladder, and as you can see, I thought I had the cystic duct here below the lower edge of the gallbladder. And if you look with ICG, then you see that my judgment wasn't quite good, and I was dissecting the common bile duct, and the cystic duct was much higher up. And maybe you could get the anatomy clear just by dissecting, but it really, really helps you to see where the anatomy is, what your common bile duct is, what your cystic duct is. So it helps you to get out of trouble. So you can clip it and put the clip just where you want to have it so you don't damage the common bile duct. And at the end, you can control again to make sure that everything is intact. Another example of a common bile duct, which is a little bit higher than we expected it to be. Here, if you look from the beginning with ICG, you immediately have the anatomy clear. And you see that what I thought was the common of the cystic duct was the common bile duct. And again, of course, if you do a dissection of the callose triangle, you will at the end will figure it out as well. But now you see it immediately, and it really helps you to speed up the procedure and make it much safer. So what's the evidence for the use of ICG in laparoscopic cholecystectomy? There's a recently published a review article from the Netherlands, and what it showed that it's safe, it can replace the intraoperative cholangiogram, and for me personally, really important, it reduces your OR time to assess anatomy. It just makes it quicker. Currently also a randomized study, the Falcon trial in the Netherlands, but we don't have the results of that at this moment. So the next reason to use ICG is perfusion. And this is an example. This is a patient with a right hemicolectomy, and the dissection is already done. And we give ICG at the moment that we want to do the last resection, just to use the stapler to see the dissection line. And you clearly see the difference between what is still vascularized good and what is avascular. And you can use that when you want to put the stapler, but you're sure that you have a well vascularized. colon remnant, and you can make an anastomosis safely later on. This is another example. This is after a left colectomy, and to show you that it's not always vascularized well. In this case, the tip of the specimen wasn't vascularized properly, as you can see here, and we had to remove the last section of the specimen. Another example, this was a patient after a laparoscopic low anterior resection, and we looked at the rectal stump, and it wasn't completely vascularized. So what we did, we shortened the stump a little bit, and after that it was vascularized properly, so we could make an anastomosis safely. So how about the literature for colorectal surgery? This is also a review of literature from the Netherlands. This shows you if patient had near-infrared imaging available, how many times did it change your surgical plan? And it showed that it changed the surgical plan in about 10% of all procedures, which ended up in a reduced leakage rate of about 50%. So in the patients group with ICG, they had a leakage rate of about 3.5%, and in the group without ICG, they had about 7.5% leakage. Other reasons to use ICG in colorectal surgery. In this case, a patient had an AVAR, an endovascular procedure for an abdominal aneurysm, and this patient deteriorated 3 days after surgery, and the vascular surgeon did a CT scan, and the CT scan showed thickening of the sigmoid, which suggested ischemia of the bowel, and when they did an endoscopy, it looked quite horrible, to be honest. They saw ischemia, and it looked full thickness, and we decided to do a laparoscopy with ICG to see how the vascularization of the sigmoid was. And as you can see, it was vascularized good, so we decided not to resect the sigmoid and just waited till the patient recovered, and it actually did recover at the end. Another example when you can use ICG is to exclude or prove small bowel ischemia. In this case, the patients on CT scan showed signs of small bowel ischemia, and we again decided to look with ICG, and you can clearly see that part of the small bowel wasn't vascularized properly, and we decided to do a laparotomy and asked the vascularization of the vascular surgeon to do a revascularization, and which was actually quite funny. When we opened up the bowel, the small bowel, which looks completely ischemic with ICG, actually looked relatively good for now, but in the truth is that with ICG it clearly showed that it was not vascularized properly, so we had to do revascularization and resect the pieces which were avascular. So just the last section, the last subject which I want to describe, and that is where I use it for liver resection. This is a little bit different. If you want to use ICG for liver resection, you have to give it 2 or 3 days before the operation, because it only has to be left inside the metastasis and it has to be cleared from the liver. And as you can see here, that if you give it 2 or 3 days for the operation, the only place where it's left is in the metastasis, and you can use it to make sure that you have a clear margin. Of course, you still have to use the ultrasound to get your margin clear, but it helps you just to get your margin clear. Here is a second metastasis in segment 4B, and it nicely shows that it extends beyond the ligament, and you have to consider it when you are doing your resection. So I want to finish off with final thoughts from a colleague from America, Matthew Albert. And he stated that ICG alone will not prevent failure, but not listening to ICG will guarantee failure. And I think if you take this, I think this is, you will have learned something from this webinar. Thank you very much. Walter, back to you.
Okay, thanks a lot, Colin. That's very clear, and you see that there are a lot of options. So may I have just one question in between? People are wondering, how do you bring the ICG into the bowel? That was the question coming up.
Inside the bowel, no, you give it intravenously, and then you see the vascularization.
So what is the time delay? When do you have to give it? You mentioned for the liver, you have to give it earlier?
Yeah, for the liver, it's way earlier. But if you want to see it in intravascular, you have to give it and look immediately, because it circulates immediately. And the half time, like I said, is 4 minutes. So in 4 minutes, it's cleared from the body, from the vascular system, so you don't see it anymore. So you have to give it when your system is ready to go. Otherwise, you can't see the effect anymore.
Okay, perfect. Thanks, Colin.
So I will proceed with mainly colorectal, and I just add one slide because ICG started 100 years before. In 1852, it was the first documented paper where the ICG it was discovered that it was just presented as a fluorescence, as a natural fluorescence. And it is the oldest and best known fluorescence dye working with near infrared. And as Colin said, the FDA approval was in 1959. And due to a very, very special maximum of nanometer of emission and absorption, it is no disturbance with blood and water, so you can easily use it in the abdominal cavity with the blood, and gives you best results. And the depth of detection is up to 1 centimeter. So usually the complete thickness of the bowel wall will be demonstrated with good or bad blood supply. And as said, you need a special equipment. Usually you can make an update of your equipment. The only thing you need new is the camera and the optic. And of course, you have to take care if the patient has a hyperparathyroidism. And the goal is, of course, of every surgeon, as we discussed in the last webinars, that we have a perfect anastomosis and a low leakage rate. And I showed this picture in the second or in the first webinar. And you need the best blood supply, no tension, good lumen, and of course, technical best skills. And the best blood supply, we realized you cannot every time do it just by looking at the anastomosis. ICG, I use it since more than 2 years, gives you really a good support. So the question, Walter, you asked also the timing of application. We made a protocol on more than 100 patients, and we realized that the average of appearance in the optic when you see the color coming is 25 to 39 seconds after application. So as Colin said previously, you have to be really, really ready, and the staff in the OR must everything finished, the lights are down in the OR, so then you can say the anesthesiologist to just give it intravenously. Then it takes 25 to 39 seconds. And this time is depending on the blood pressure. So if you have a very low blood pressure, you will see a low fluorescence effect and coming very slowly and late. And if you have a high blood pressure, then you will see it immediately in good presentation, good color. So this is what we found out. I show you some pictures now, some slides. So this is coming the specimen out of a Pfannenstiel incision of the low rectal cancer. And you can see easily here the vessels in the meso. You can see the complete descending colon. And here is the bad point where you have to just cut the bowel. And you always have to look at the posterior wall, because sometimes the serosa has it 2 centimeters more, and on the posterior wall it's 2 centimeters back. So you have really to inspect the specimen, the descending colon in left colectomy on 330 degrees because of it's not continuously on the same level. On the next slide, you can see intraoperatively where we have the anvil already put inside, and as first you can see the iliac vessels coming here, and then secondly is the iliac vessels. It comes to the descending colon, and you have to check if really everything where the anvil is with good blood supply. And we did it just before for demonstration now for this to show it when it comes. Usually, of course, you have to do this ICG demonstration before you put in the anvil. But you can see here, completely surrounding the blue color. This is one of the differences to the systems. If you use it from the one company, I don't want to name it, it's blue. And if you use it from the other leading company on ICG, now you have it in green color. So outside you are, this is a transanal specimen retrieval for a conoanal anastomosis after a very low rectal cancer. And of course, you can use it also in outside the abdominal cavity to check if the descending colon has a good blood supply. Just put it out through the anus and check it just 360 degrees on each side, that you have a good blood supply. Here is an example where we had to change strategy. This was in a time where not all of our staff took it routinely, and then after putting the stapler together before firing the anastomosis, it looked a little not so good blood supply. You notice sometimes if there's a big tension due to a big stapler, it sometimes look a little darker. And so we checked it inside, and then we have not been sure if the anastomosis is good. So we did ICG, and you can see when the vessels going in first, the vessels, and then you see there's just 2 centimeters, there's no blood supply. So we had to do a redo of the anastomosis. And this is what is definitely worth to take your time. Better to do the ICG before the anastomosis, but in that case, we just had to do a re-resection. You can see the stump, perfect blood supply on the rectal stump, but no blood supply here on the anterior wall of the descending colon. In that case, you will have to do a new anastomosis. And if you check it in just the regular light, you can say now, okay, this looks bad, this is not so good, but it is definitely no good blood supply. Right colon cancer, doing intracorporal, extracorporal anastomosis, that is a case, laparoscopic assisted, doing extracorporally. And of course, the same style, you have to just wait for half a minute, then the blue color will come. And therefore, it's also important that the meso is not just squeezed to a small incision. Many surgeons do the extracorporal anastomosis. I would suggest better doing intracorporally because there's no risk for twisting the colon, but you had this on the last webinar, the right colon cancer. And here you can see just exactly as Colin showed the region where you have to cut the bowel for a safe anastomosis with good blood supply. And even the small bowel, sometimes you have a bad blood supply in the small bowel, which shouldn't happen. However, we analyzed the literature, and we found that you might find more leakage on right hemicolectomy than in left hemicolectomy, and maybe sometimes it's due to the small bowel. And of course, you can do it also intraoperatively if you want to check the anastomosis. If you just have not a good feeling and you don't use it routinely, just then check the anastomosis if everything is in a good blood supply condition here, as you could see in the picture, in the video, that even the small bowel, this is an isoperistaltic anastomosis, and the large bowel are in good blood supply. So this is just some examples from the OR. And going to the literature, I want to show one of the first papers of one guy who did a lot of papers on that, is Jafari. And he found that in one of his first series out of 40 patients, he did in 1/3, in 16, he did ICG with near-infrared, and in 24, he did just a regular anastomosis resection without ICG. And in 3 times, he had to do a re-resection due to ICG. And he had, in this group, only 6% of leakage, 1 leak. In the other group, he had 18%. So this is 3-fold higher. Although the anastomosis was lower in the ICG group than in the regular group. So he could found a significant lower leakage rate using ICG, and you will find this in all the papers. So there's another paper from the same group now, from Jafari, now almost 140 cases of colorectal resections, and he had 11 times he had to do a redo, as shown in the video, when he found that the anastomotic part of the bowel is not in good condition, not best blood supply. And in the group of the redo patients, he had no leakage, and in all the others, he had 1.4. So you can see in all cases, he had to do a re-resection, a redo. He had no leakage at all. This is what gives real good feeling and good support for using this very simple and cheap technique. Another group, Luigi Boni, he is also very active in colorectal surgery in Italy and also in ICG, published 4 years ago 107 resections, all right, and splenic flexure left and lower anterior section. He had to do 4 times a resection, and he had 1 leak in the complete group, and this was in the right colon cancer. So this paper just appeared last week, and this is a big meta-analysis of 11 studies, including 3,000 patients, and they could found, analyzing all the papers, 11 studies, that there is a significant lower anastomotic leakage rate if surgeons use the ICG. And you can see on the very right part of this table that there is a reduction in leak rate in different groups in 15%, 10%, 3, 12 times. So there is a significant and a very high impact for the use of and the benefit of using ICG in colorectal surgery. And another review in the same paper published in August, 3 weeks before, they analyzed 13 studies, 4,000 patients, and 1,800 had ICG resection with ICG, and 2,231 had without ICG. And they found in the leak rate in colorectal surgery that the overall leak rate in the ICG group was 3.8%, in the group without 7.8. It's almost double. It's statistically high significant. And the reoperation rate was in the ICG group 2.6%, and then the regular group without ICG almost 7%. Also highly significant if you use the indigo-threonine. So many papers now, and all the literature goes definitely in a high impact and a real benefit for the patients if you use this simple technique. So they conclude after this review that the use of ICG could lower the risk of anastomotic leak rate and decrease the probability of a reoperation in patients after colorectal surgery. So this is almost the latest literature on ICG, and Colin started already on the metastasis, just one paper on that. They compared the group on the pancreatic cancer and liver metastasis using ultrasound versus laparoscopy versus ICG, and they analyzed 25 patients and wanted just to analyze and have a look on if they could reduce unnecessary laparotomy just for cases for staging if there are unclear cases in the CT scan and MRI. And they could found in 25 patients seven unexpected lesions. So this is just almost 22%, and 4 of them have been benign, but 2 of them out of 25 patients had liver metastasis, which they didn't expect. So the authors conclude on that paper, which was published 2 years ago, that it has a role in staging due to the high negative predictive value in case of suspected lesions, and if there was no doubt at all, they could found it also by use of this technique. Finally, another paper on liver metastasis from colorectal cancer. I just go on the slides. In that paper, they could identify in the group 45 lesions suspected for metastasis by CT scan. And out of this group, they did additionally found 10 by use of intraoperative ultrasound. So the total group now is 55, and extra by use of ICG, and this is the PDI is just the infrared camera, the name of the infrared camera. They found another 23 patients, so they could just found out 78 patients. Only CT scan it was 45, CT scan and ultrasound 55. So this is highly impressive if you use it correctly, what you can do for benefit for your patients. So Walter, ladies and gentlemen, let me conclude. The ICG near-infrared is a really, really safe and simple and cheap tool to demonstrate and document the real-time blood supply. It gives you a help if you're not sure, and it is the best if you use it routinely to just reduce an unnecessary leakage rate to give you just a very low complication and reoperation rate in colorectal surgery. And of course, to make the take-home message complete, it's a very good tool. I didn't go on bile duct because it was colic, but to document the extrahepatic bile duct. So we use it just if we expect a difficult cholecystectomy, Merizzi syndrome, abscess formation, then we give it 1 hour prior to the operation. You see the bile duct. And of course, it might be a good tool for the liver metastasis. You need more routine on that to get familiar with the system. This would say is in advanced surgery. And maybe there are just gynecologists doing lots of studies now. It might be also good for finding the sentinel lymph node, or generally just metastasis positive lymph nodes. We have on the liver metastasis and on the lymph nodes a lack of valid studies, but we have real good studies and just reports and reviews and meta-analysis now on the benefit in colorectal surgery. One thing is left that companies are working now, the intensity of the color to be quantified. So we can just say there is blue light, green light, or no, but in very new latest systems, they now also give you the real intensity of the blood supply. So they can give you per the computer if the blue is just high, medium, or low blood supply, which, and this is now difficult to give the color and the brightness of the light, some count 100%, 80, 70% blood supply. But this is the next generation, which will appear for routine use soon, as well as the use in colonoscopy. It's on the market available now. Unfortunately, we have it not completely installed. We will start with this at the end of the year, but it works already. We had the demonstration. You can also use this for proving the mucosa using colonoscopy or gastroscopy. This will be the next step. Thank you for your attention.
I just pick up one of the questions. There are more, and we will discuss them later for you, because you showed very nice that we are able to reduce leakage rate around 10 to 15% in the comparison to non-use of ICG. But the question was there, even if we know there is ICG had a good result, but then we have a leakage, and they wonder what is the reason for the leakage if blood supply obvious is good enough. What do you think, Andreas?
Well, what we surgeon can do, we can approximate two ends of the bowel by stapling, by suturing. We can take care that there's no tension, there's the best blood supply. But the healing is another different chapter of the book. And this is what we not always can influence. And sometimes
Absolutely
we have a breakdown, which we don't know why, even everything is perfect.
Well, I hand it over to Colin already. What would you say?
Yeah, I agree with there's so many different factors with influence. There are now studies on the microbiome and which appear to have effect as well on the healing of the anastomosis. So I think there's still a lot what we don't know.
Yeah, there are obvious a lot of factors contributing to perfect healing. There's also genetic, there's microbiome, as you said it. Even if we have perfect blood supply and tension, we can have microthromb afterwards in the days after the operation. So it's not only, this is only one fact. Okay, perfect. We count a lot of questions and we will take them later on for you both. And now it's an honor and pleasure to have our guest from today, Ahmed Shukri, who is the head of the minimal invasive and the chairman of the department in Egypt. And it's really a pleasure to have you here, Ahmed.
Thank you, Walter, and thank Medtronics for the kind invitation. Our case is a very interesting one because it has a lot of complexities. It's a 34-year-old gentleman who presented in late 2019 by bleeding per rectum, and he was subjected to clinical investigations, and he had a colonoscopy, and I discovered a rectal tumor 4 centimeters away from the anal burr. This was in a peripheral hospital. This was not in our center. He had the CT scan then, and then he was sent for neoadjuvant concomitant chemoradiotherapy. He received 4,500 centigrades of radiation over 5 weeks together with Zeloda. He had an MRI post-neoadjuvant treatment, which showed a regression of the tumor, but still there was still residual tumor. And then he was referred to our center in February 2020 because he was looking for a sphincter saving surgery, and he was given the option of an APR in most of the centers that he went to. We reviewed the case and we operated on him around 12 weeks after finishing his neoadjuvant treatment by an intersphincteric resection. But what was really interesting for this guy is that in 2001, he had a laparotomy and exploration for intestinal obstruction. And he said that he had a small bowel resection, and there was absolutely no data about that, no medical reports, no X-ray or imaging studies from that event. And then in 2008, he developed non-Hodgkin lymphoma, to which he received chemotherapy, and he's now in remission. And in addition, he had also an open appendectomy. So a lot of complexities in addition to his ultra-low rectal cancer. This is the available CT scan from the peripheral hospital that was done pre-neoadjuvant treatment, and it shows the lesion at the level of the seminal vesicle and spanning until the prostate. Post neoadjuvant treatment, he did an MRI which showed a regression of the lesion quite significantly compared to the preoperative size, but there was still a few small lymph nodes in the mesorectum, and a small lesion was still detected in the MRI. This whitish area scarring in the anterior part, this was the residual tumor, and these are the small lymph nodes. This is the abdominal picture of this patient with the midline exploratory laparotomy and the huge appendectomy scar. This is where we have managed to put our ports, and this is the final specimen. This is the residual tumor with the achieved around 1 centimeter negative margin. And to go ahead with the video to show you what was really happening, there was a lot of adhesions and it was very difficult to go into the abdomen. And the problem was that the whole small bowel was an amalgamated mass overlying the mesentery of the colon. And what we're trying to do here is we are trying to lift the whole small bowel away from the mesentery of the colon. And the trick here is that we really don't know where is the mesentery of the small bowel and where is the mesentery of the colon, and you can end up injuring or devascularizing colonic segments, and these are the segments that you need to mobilize to reach down to the pelvic floor as the patient has a very low rectal tumor. So it was really a tough dissection and really very risky. And this is why the value of ICG would come in later on, because we need to verify that the vascularity of the colon is intact before doing the actual resection, because all of this is not part of the rectal tumor management. This is just adhesolysis, and we are trying to release the small bowel away from the colon and the colonic mesentery. And you see here the proximity of the colonic wall, and this is the whole colonic mesentery right here, and together with the small bowel adherent to it. And in addition to the risk of vascularity, we need also to liberate the colon all the way up to the transverse colon for it to reach down to do an anastomosis coloanal. So it was really a challenge on how to bring down the colon, lyse all the adhesions, and be very careful not to injure the vascularity of the colon, so that you will end up with no colon to bring down in the pelvis. And this really is the area of the vasculature going to the colon right here. So it was very tough dissection. And reaching to the mid-transverse, now we are releasing all the attachments. Now the dissection has ended and we have exposed the retroperitoneum completely. And this is the view of the retroperitoneum right there. And this is the inferior mesenteric artery. We have finished dissection of the medial to lateral plane. And now come in the ICG. We injected it intravascularly, and you see very nicely the inferior mesenteric artery. And what is more interesting to us is the arborization of the vessels in the mesentery of this is the left colic right there, and you have a good blood supply. So now we have documentation, and we made sure that we did not injure any of the major vessels supplying the colon, and we have a very nicely vascularized colon. And we have also planned what to do, because we wanted to spare the left colic artery and to do a selective ligation of the inferior mesenteric artery. We have taken down now the vein, and then now we are doing the lymphadenectomy around the artery and exposing the origin of the left colic, because we wanted to spare the left colic to ensure good vascularity. And you see here, this is the origin of the left colic of the inferior mesenteric vein, artery. And now we are completing the lymph nodal dissection around the vessel, clearing the left colic branch completely and preserving it as well. So now we are going to ligate the inferior mesenteric artery down after the takeoff of the left colic artery. Now this is the vein again. We ligated the vein again downwards, and now you have here the released lymphadenectomy specimen and the remaining part of the vessel. The final step in our resection is cutting down the mesentery down to the colonic wall at the suggested area for the anastomosis. And now comes the moment of truth. If we have done a good job and we have preserved the vessel, ICG will tell us if we have performed a good job or not. ICG is injected, and you see here the inferior mesenteric artery, the left colic going to the colon, and then the color of the colon starting to glow, and you see the vasculature. The preservation of the left colic maintained a very good and nice vascularization of the bowel. And you will see that at the point where we have transected the mesentery, this is the transitional area, demarcation line between the vascularized and non-vascularized colon. And as Colin and Andreas have shown, that you need to see the vessels glowing. This is the deep vascularized part. You don't see any vessels, but here you see the branches of the vessels right there filled with the ICG and all around. This is after we have finished the perineal part, and we have the area that will be anastomosed, the colon that will be anastomosed to the anus, and we injected again to ensure before making the anastomosis. We have injected ICG again, and you see the colon is very nicely vascularized. Even the bleeding edge is showing very nicely here. So now we are quite sure that the anastomosis will have a very adequate blood supply, and our patient hopefully will do very well. So in this case, as you see, it's a very complex case. Patient had many previous surgeries unknown to us. Some of them involved bowel resections, and he had lymphoma as well. So ensuring good blood supply and documenting it with ICG was very important for us. And I hope this gives you a clue that ICG can be a very strong element in your practice if you're doing these kinds of complex cases. Thank you very much.
Thank you very much, Ahmed. This was a quite interesting case and very nice solution you tried to pick in. So now the discussion, of course, is open, and I have some questions, and maybe I will start with Ahmed. So there is one other question I just picked up from the beginning. You said that you do the operation 12 weeks after ending of the radiochemotherapy. So this is in countries, and Colin said that in the beginning, hospitals are different, countries are different. So just let me ask that in your country or in Egypt, is that typical that you wait 12 weeks after the end of radiochemotherapy to make the operation?
Not in Egypt. You will not find a universal, uniform practice. Every institution varies a little bit. But now in our oncology center, we try to operate around the 10th week. We operated on the 12th week in this guy because there was the COVID problem, and we operated on him in March. It was the beginning of the peak in Egypt, and the guy came to us a little bit late because he tried to visit many centers because he was offered an APR in most of the centers until he reached us, and by that time it was COVID, so we had a little bit of delay. So we operated on 12 weeks, but we target on operating on the 10th week as by our protocol nowadays.
Okay, perfect. So let's go back to ICG. So in your hospital, you showed that you will test very close because it's the bowel, and there was another question for that timing delay. Andreas showed that very nice. But so when will you test? We saw several testings, but can you explain it again? How much dose you give, and what is the time delay when you give it? How do you give it, and when do you have a look at it?
Because we are doing basically an angiography, so all your testing is immediate. You inject, and then you have to be there with the near infrared light because it will take only around 20 to 30 seconds to show, and then it will fade away. So if you need to capture the good image with the nice blue color of the vessels, so you need to be immediate. We dilute the ICG in around 10 cc's of sterile water, and we use around 3 cc's every injections. That will give us a good concentration and a good vascular pattern, and we can repeat it several times during the surgery. It's just one vial. We did not have ever to go beyond one vial, and this is way in the safety profile of the ICG.
Okay, I think we all four agree that for colorectal surgery, you inject venous, you have in the arterial system after around those 25 to 60 seconds, as Andreas said, and as Colin mentioned, after 4 minutes, it's gone. So you can check, and then you can check after 10 to 15 minutes, you can check again. Meaning, for example, what we do in our hospital, we are checking before we cut the colon. We have the dissection pretty nice. We decide where we want to resect. We make the ICG, and then we cut. Of course, we can do then again an ICG when we do the anastomosis. And actually, we do it from outside and from inside if it's a very low one. So if it's a very low one, we can go there with the camera. And after performing the anastomosis, you can inject again, and you can have a look from below also and look on the anastomosis. And as Andreas said, there will be endoscopes will be able to show that too. So if you have availability in your hospital, you can do it by the colonoscope, or if you do, for example, esophageal resection, you can do it with the endoscope too. Andreas, can you tell us about that a little bit more?
Yeah, it works the same as in laparoscopy, in flexible endoscopy. We had it for testing in our clinic, and it don't know why it just will take another few weeks that we have it in the routine use. But you can see the mucosa, the same color and the same intensity, just giving the good blood supplied area or area without blood supply. It's really very easy.
Exactly. I think
from that.
Colin, yeah.
What would be the benefit from just adding that? What would it add on the laparoscopic picture?
So if you're not sure from the laparoscopic point of view, then you can get your decision-making, your support. If you also feel in the endoscopic mucosal view that is not the best, then you have to react and do a new anastomosis.
Exactly. Okay, let's go further. For Colin, I have some questions. There was the question, you brought it in that if there is an allergy on iodine, you would not give it, but you did not ever see. But there is another question about anaphylaxis, and what would be the treatment about anaphylaxis on if you use ICG?
Well, there's a standard protocol with contrast allergy, and patients get corticosteroids, and it depends all on the reaction of the patient. So I expect that everybody has a protocol in his hospital for anaphylactic reactions. And again, depending on how severe the reactions are, if it's also with hypotension, they give, sometimes they need vasopressive substances or medication, but most of the times it's just corticosteroids.
Andreas?
Well, there is the recommendation from the company that you have to check the FT3 and FT4 and TSH if there's a overfunction of the thyroid gland. So then usually it's a contraindication.
Okay, Ahmed, in your hospital, do you have a look on that?
We never had an allergic reaction, but we know about this iodine problem. And coming to that, there are some companies now that they have ICG without the iodine. So they manufactured a form of ICG that is iodine free. I'm not sure which company is doing that, but I'm aware that there is a company that is producing ICG without the iodine part, specifically for this allergic problem.
I think that's important to be aware that there could be an allergy, and you are prepared for that you ask that first. So for all participants, I think that is really, you have to read clearly if you use something. But on ICG use, that's very important. There was another question for Colin. What about renal impairment? If you use ICG, are the kidneys somehow attached by that?
No.
No,
it's
not at all.
Completely by the liver. So. No
but
problem.
Can you see the ureter? That was a question. And when do you see it?
No, you need a special agent for that. And it's not on the market, it's still experimental. I've seen a couple of studies with it, but then you need a fluorescent substance which is cleared by the kidney, and then you can see the ureter, but it's not available on the market yet. So you need something different than ACG. You can do it with fluorescent, but a different substance.
Okay.
You can put ureteric stents. If you want to visualize the ureter, you can put ureteric stents and inject the ICG inside the ureteric stents, so it will fill the ureter, and then you can visualize it laparoscopically. But you must put in the stent because it's acting local, not through a nephrogenic excretion. It's like it's the same as intravascular. It's intraureteric, but through ureteric stent. So Luigi Boni is doing that. I learned that trick from him in difficult diverticular cases when you have a big phlegmon overlying the ureters. He put the ureteric stent in and inject ICG to fill the ureter, and then visualize it laparoscopically.
It's somehow similar like the lightning ureter catheter. You can put in and just put the light on that. So
yeah, probably this is cheaper, probably.
Probably that's cheaper. Okay, then there were some questions for the liver. If you use it in liver surgery, you said you have to give it before. Andreas showed that's 1 to 2 days before. So how do you do that, Colin?
We give it about 2 to 3 days before the operation. It doesn't. The most important part is completely cleared from the normal liver. So that's why you give it a couple of days in advance. But I'm still gaining experience with that. So I'm still working on whether or not it's really adding, if it's really helping me to do laparoscopic surgery, because it only helps you when the liver metastases are superficial, and when they are deeper into the liver, you can't. It doesn't help, because you don't see the fluorescence. So it helps you a little bit when you want to do resection for superficial metastasis, but deeper you still need the ultrasound.
As you showed that you can detect some of the liver mets via ICG you did not see before. There was a question if PET-CT would always help and be better than ICG, or what is the comparison if you do a PET-CT for a liver met versus ICG?
Well, currently for localization of the liver mets, we do an MRI, which is standard in our hospital, and we do a PET scan for extrahepatic disease. So the PET scan is not so, how do you say it, sensitive for localizing liver mets. It needs to be a certain size to be visible on the PET, so the MRI is much more sensitive. And so,
but I guess
and it's not during the operation. So this is a big problem. The PET-CT is, of course, before the operation.
Yeah, and also the MRI is before the operation. But again, all those patients where you found additional mets with ICG, I think they had MRI.
Yeah, that's true. But the chance of when we didn't do standard MRI, we had a CT scan, and then we had about 20 to 30% we found extra liver mets during the operation with an ultrasound. And now when we're using MRI, that number is going down quickly. And the chance of finding something which you didn't knew before the operation is quite small, except if your waiting period is too long. But
okay. There was about the cholecystectomy also some questions. The one is the timing was again a question. And I think that for all the participants, you can have these lectures. You can look them up later on. So Andreas had a very nice slide in where you see the timing, where you have to inject, and then you see it. So that's for the liver. That's also if you do laparoscopic cholecystectomy or for the colorectal surgery. This was very nice, and you will find that. But the question was, what about routine use of a standard in laparoscopic cholecystectomy for the residents? Does anybody consider that? Would that be an option?
Yeah, in my hospital, I prefer that the residents use it because they have the anatomy clear from the beginning, and it doesn't. They still have to dissect triangle, but it makes it safer for them. It's an extra help, and it just makes it safer. It's easy, it's cheap, and it makes the anatomy much clearer from the beginning. So
you for every cholecystectomy you do it routinely before they go into UR, or when do you inject it then exactly in your hospital?
We give it about 30 minutes to 45 minutes before the operation, and then you can see it quite clear. And we give it to all patients. It doesn't always benefit you because there are sometimes really obese patients. You don't see the common bile duct, but it's so cheap that I don't see a reason not to use it.
Yeah, I come back to the costs, but maybe Andreas, I will ask you and Ahmed in your hospitals, do you do routine for laparoscopic cholecystectomy?
So we don't do it routinely, but we do it selectively. If we expect a difficult cholecystectomy, we give it intravenously on the ward 1 hour before the operation. Our experience is that if you give it too short, just 30 minutes, sometimes the liver is too much lightening, so you can get it clearly. So we do it 1 hour prior to the operation, and then, as I said, the thickness is about the depth, it's up to 1 centimeter. So of course, if you have very fatty patients, it's difficult. If there's much edema in the ligament, hepatodenal ligament, it's difficult. But in many cases, you can identify the common bile duct from the very beginning of the dissection.
Okay. Ahmed, what is in your hospital?
I'm an oncology center, so I don't do cholecystectomy routinely, but I would, if I am using it, I would use it in every case because it's really cheap, and if you have the tools, it's an add-on safety measure. So it's no problem. You should use it. If you have it, you should use it.
You all say it's very cheap. So the question is, don't you need an own system, which is very expensive to be able to do ICG, or you just put your camera you have in your hospital and that's enough? You just give it?
No, of course you need a special system, but it's not the most expensive system. You need a special light source and a special camera, but it's an investment worthwhile. I mean, if you prevent one leakage with ICG, I think it will. It's a return in investment already. Yeah.
Yeah.
But there's I think most of the companies now, all the new towers are ICG enabled. Most of them. I don't think that you will have now a tower, a laparoscopy tower without the ICG module in it. built in, I guess.
But there is not any study on a cost effectivity within the use of ICG routinely on lap chole or bowel surgery. There's no study for the moment. But I think we all agree that, of course, you need the set. You can use it, by the way, for any laparoscopy. It's not a special you can only use for ICG, but you can make the whole operation with the same camera, but it's a special camera and a special light source. That is what you need. And then the simple one to inject, and you can inject as much you want, and as often as you want, you can use the same camera. And the injection itself, it's very cheap and it's easy done. Andreas?
Well, in our system, we have a well-known company for a laparoscopy unit, and the update was 4,000 euro per tower, and the single use in the OR, just the dye, is 45 euros for one procedure. And so this is really cheap, and the update is just one time 4,000 euro if you have a full equipment. I have an offer, it's now four months old, from a company who just wanted to sell us a tower only for ICG, just putting in the OR beside your laparoscopy tower, also with a module for hyperparathyroidism for the thyroid gland, and the complete package with an laparoscopy and then external camera is 140,000 euro, the complete system. So if you have a good system, then it's a cheap update and a cheap single use.
Do you use your laparoscopic system for open surgery too, or do you have an own open camera and the laparoscopic camera?
So we have it both. We have small laparoscopy cameras in 30 degree and in 0 degree, cameras like that, to put on the regular laparoscopic camera, the optic, and in open surgery, we just use the short camera put on the laparoscopy tower.
Okay, Ahmed?
No, I use the laparoscopic one because I don't have the open, the dedicated open cameras. I don't have. I'm using the laparoscopic one.
Okay, Colin?
Yes, same as Ahmed. We have, if I use it in open, we use the laparoscope, the endoscope.
The important thing is that if you use that, you have to put away the normal OR light, because that influences. So you have to put it in a way. And actually, we also have an open one. We use it for thyroid also. That's very parathyroid. That's very good. And for open surgery, there's a big difference if you have the open camera, because you have to dim down really very much to see it with your laparoscope in the open setting, especially for the bowel, for example. That really helps a lot and makes a good decision, especially in the night. If there is an incarceration and the bowel is not good, you can use it for that. Okay, Andreas, another.
Two remarks which we didn't mention so far. If you start putting it intravenously, your anesthesiologist has to be just also informed that because of the oxygen saturation goes down below 80 sometimes. So if you have a young anesthesiologist and he's the first time in the OR, he doesn't know what's happening, the saturation, the oxygen saturation goes down below 80. And second, another application which we use sometimes, if we go to our friends, the gynecologists, and they do a laparoscopic endometriosis, and sometimes it's really bloody in the OR, and then you want to find the diffuse bleeding, then you can also give the ICG and you will find it from where the bleeding comes from very clearly.
How do you explain the desaturation to 80?
Because the dye goes on the red blood counts.
I've never heard an anesthesiologist complain, but let's check it.
Okay, if there are no more questions, I would thank you very much, and I would suggest for all the participants, we gave you for our next webinar, module 6, the complications during surgery and how to deal with them.